So this is a case presentation titled Trapped in the Heart, Fracture Pacemaker Lead Complicates MSSA Endocarditis Management. My name is Sungmo Hong. I'm with the University of Texas Health Sciences Center here in San Antonio, and I also have my colleague here, Nicholas Tyndall. He's at the Uninformed Services Health Education Consortium in San Antonio. And so before I go into like an introduction real quick, I just want to give a brief summary of this patient case, or at least just give a quick background. This is a 60-year-old male with a complicated cardiac history coming in with recurrent left foot infection and osteomyelitis. Um, and so this case ended up being an interesting infective endocarditis case. Infective endocarditis, to give a brief summary, is a infection that typically involves cardiac valves, mural endocardium, septal defects, and indwelling cardiac catheters. Since 1990 to 2019, there's been a significant increase in the global prevalence of infective endocarditis from around 478,000 to around over 1 million. And as technology has advanced and we have more prosthetic valves and cardiac implantable devices, the number of cases relating to prosthetic valves or cardiac implantable devices have increased. And so CIED, which is abbreviation of cardiac implantable devices, endocarditis, is a lead-associated infection, and it makes up around 10% of all IE cases at the moment. And so we did a brief literature review looking at what other similar cases there has been. And since 2019, we were able to find 3 cases that were similar but not exactly alike. What we've noticed is that most of these cases, patients tend to have complicated cardiac histories and a large associated comorbidities. Presentations tend to vary significantly. The most common symptoms tend to be fever and fatigue. And typical management involves identification of risk factors, culture evidence of bacteremia or like bacteria in the blood, image findings, and device removal. Our case is particularly interesting because the device removal resulted in a complication where the lead that was inside the heart ended up breaking, and so they weren't able to fully remove the infective source. So going to our case presentation, this is a 60-year-old male with a past medical history of atrial fibrillation on Eliquis, bifascicular block, sick sinus syndrome, coronary artery disease, status post-CABG, and percutaneous coronary intervention, and preserved heart failure. The principal problem upon admission was a recurrent left foot infection and osteomyelitis. This patient, interestingly, wasn't feverish on presentation, so this goes to show the wide presentation that's possible for infective endocarditis. Overall physical exam was mostly pertinent for the bilateral lower extremity edema and left lower extremity erythema up to around the mid-shin. And so we ended up getting some labs. It showed low hemoglobin levels and elevated alk phos. And so based on those initial findings, the initial differential for our case was possible cholelithiasis, maybe like a stone in the gallbladder somewhere, osteomyelitis, like a bone infection, or some sort of intraspinal abscess. And so upon further infectious workup, we got an X-ray, a right upper quadrant ultrasound, MRI, and blood cultures. It turned out that the blood cultures were positive for methicillin-sensitive Staph aureus. And so this triggered the Duke criteria. And so from there, we were able to satisfy the first major criteria, which was the presence of MSSA bacteremia, and a second minor criteria for predisposing heart condition. And so after that, we did additional image workup. We got a transthoracic echocardiogram, and that was inconclusive. And so we ended up getting a TEE, which is a transesophageal echocardiogram. And if you look at figure 1, you're able to see the right ventricular lead vegetation. So that's where the possible source of infection was coming from. Upon discussion with the infectious disease doctors, they confirmed the presence of a lead-associated infection, and they recommended that we do a procedure to remove the infected lead, as if we left it in, the likelihood of it progressing to a systemic infection would be very high. And so vascular surgery got involved, and they were able to remove the infected lead. And while they were trying to pull it out, due to whenever there's a foreign body in our system, there tends to be an inflammatory response, and that resulted in the lead not being able to be removed as effectively as they would have liked. They tried multiple attempts, and it resulted in a fractured lead. And so there was a lead. The right atrial lead was able to be removed, but the right ventricular lead was stuck within the right ventricle. And so multiple attempts were made to remove it, but it was deemed too high a risk to continue with removal. And so after surgery wasn't able to retain the lead, we spoke with infectious disease, and they recommended that we continue with IV antibiotics and monitor for clinical improvement. And luckily for our patient, they continued to improve. Patient was clinically stable, and he was eventually discharged to a skilled nursing facility. There he was given IV antibiotics, and then upon being discharged from the nursing facility, he was started on a long-term oral doxycycline, just for chronic immune suppression or chronic suppression of the bacteria so that it doesn't come back. At the moment, he's being followed up with cardiology to ensure that the retained lead isn't going to cause any other issues and ensure that the patient has overall good recovery. So overall, this is an interesting case presentation of a 60-year-old male coming in with an infective endocarditis case that resulted in a retained lead after surgical management attempted to remove the cardiac device, and now the patient is on long-term antibiotics as a result. And if there's any questions, I'm happy to take them as well.
Thank you so much, Sungmo. One question that was given to me was just given how complex these infections can be, multiple comorbidities, as a physician trying to take care of these patients, like what are the most important aspects of care that you should focus on to try and just improve patient outcomes long term?
Yeah, sure. So with infective endocarditis, there's been a lot of development in terms of like the type of bacteria that gets involved. In our case, it was MSSA, but there can also be like MRSA, there can be Enterobacter. These are all different kind of infectious bacteria that can make management of infective endocarditis more challenging. From the patient's perspective, to ensure that they get the best care possible, it really is a multidisciplinary involvement. For us, it was the involvement of infectious disease early on. It was the involvement of surgery early on, involvement of cardiology as soon as possible. And so I think from the patient perspective and from the physician perspective, it's best to get as much members of various teams involved so that they can figure out the best course of action for this. For these like management of infective endocarditis, especially in these cases where it's so complex because the patient has so many cardiac comorbidities and there's new circumstances like the retained right ventricular lead that wasn't able to be removed. And so that's where infectious disease really came in and was able to assist us.
Well, perfect. Thank you so much. I really enjoyed your presentation.
Awesome. Thank you.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.